Hi and welcome to another video tutorial by Synapse. Today we shall be talking about endometrial hyperplasia and endometrial carcinoma. Okay, endometrial hyperplasia and endometrial carcinoma. Okay, so this is another important topic from gynecology. Okay, so let's begin. So what is hyperplasia? Hyperplasia is excessive proliferation of cells. Okay, right? Now if this excessive proliferation becomes abnormal, okay, it becomes carcinoma, right? So that's simple. So hence endometrial hyperplasia is a pre-malignant lesion which will convert into carcinoma, correct? Okay, so we have understood one thing here, that this condition is pre-malignant, so hence we'll be careful, correct? Okay, now there are four types of endometrial hyperplasia. Okay, that needs to be understood. First, we need to understand what is simple and what is complex. Okay, see, simple hyperplasia as in there is increased number of glands. Okay, in complex there is excessive increase in the number of glands. So when this happens, it will be thrown into folds. Okay, so this appears to be having more number of folds compared to this. Okay, so here if I try to draw it here, so the gland will appear to be large and cystic and filled here, and this is the lining epithelium, let's say. Okay, there is a single layer of lining epithelium and inside it is having some kind of secretion. Okay, you're seeing dilated glands filled with secretion and lined by single epithelium. Now if I try to draw complex, okay, it will be like glands are thrown into folds like this, and you will not have single layer. It feels like you're having multiple layer of cells. It is basically like pseudo stratified pattern. Pseudo stratified. Okay, why? Because the cells are hyperplastic, right? So they're going to like increase in number. Hence it appears the nucleus will appear at different levels. So hence it appears that there's more than one layer of cells. Okay, so that is why it is called pseudo stratified. Okay, so that's a difference between simple and complex. Okay, and again two more terms to be understood. This is normal basics from pathology. What is typical cell and an atypical cell? Okay, so when you typical cell, this is nothing but a normal cell. So what are the features of atypical cell? Okay, the cell becomes large. Okay, this nucleus will become large. Okay, the nuclear cytoplasmic ratio will increase. Okay, the nucleoli will become prominent. Okay, so these are the features of atypical cell, correct? So this means there is when there is greater extent or amount of atypia, that means there is increased risk of malignancy. Okay, now we're going to try permutation combination with this and this. So let's take up another sheet here. Okay, so what are the possible outcomes? Okay, it could be simple with typical cells, okay, or it could be complex with typical cells. Okay, it could be again, next combination is simple with atypical and complex with atypical. Okay, there's some numbers that needs to be remembered here. Obviously if you see from the list, complex atypical will have greater amount of risk, okay, to convert into malignancy. Now if you write the numbers here, it's 1, 3, 8 and 30. This is like around 29, 30. You can remember 30, round figure. Okay, easy to remember. So what are these? This is the extent or the chances of which, okay, these conditions can convert into malignancy. What kind of malignancy? Endometrial carcinoma. Okay, fine. So this is having the highest risk. So it is 1, 3, 8 and 30. Okay, these are the numbers you need to remember. Now what are the risk factors for endometrial hyperplasia? When can endometrial hyperplasia occur? Okay, risk factors. See, now we know if you see the menstrual cycle, right? initial half, okay, the first half is the proliferative phase, and that is happening under the influence of the hormone estrogen. So that means estrogen is responsible for the growth and proliferation of the endometrium. So hence you need to list all those conditions where there is unopposed and excessive estrogen exposure. Okay, so that includes uh, conditions like nulliparity or nulliparous woman. Okay, she has never become pregnant, so she is always, she has higher estrogen exposure compared to a lady who is pregnant. Okay, so hence multiparity will obviously be a protective factor. Okay, and then it could be things like delayed menopause or late menopause. Okay, so it could be associated with other estrogen excess conditions like endometriosis and fibroid uterus. Okay, it could be associated with PCOS. Okay, so obese female. Okay, obesity and hypertension, diabetes. Okay, see, there is one condition here. Okay, that needs to be remembered. Okay, obesity, hypertension with diabetes in a woman who is having endometrial carcinoma. Okay, and this is not hyperplasia, but I'm mentioning it right here. So this is called as corpus cancer syndrome. Okay, that is called corpus cancer syndrome. Okay, it is not related to hyperplasia, but I have mentioned it here. That is to be remembered. Okay. Okay, so let's move ahead. So we spoke about nulliparity and all those estrogen excess conditions. Okay, and also you can mention tamoxifen therapy. Okay, the drug we give for breast cancer. So it is having like selective estrogen receptor blocking activity. It blocks the estrogen receptors in the breast, and then it has a positive stimulatory effect on the estrogen receptors on the endometrium. Okay, so that is associated with higher risk. Okay, fine. So now they will develop endometrial hyperplasia. Now how will they present to you? Okay, see, compared to carcinoma, okay, carcinoma cervix and endometrial carcinoma, what is the difference? Cervix, now the patients do not present early. Okay, because the symptoms will develop later on. But endometrial hyperplasia or carcinoma, they'll present early because they'll have symptoms, development of symptoms. So what are those symptoms or clinical features? Okay, see, there is endometrium. Okay, increased proliferation of endometrium. Okay, so how much can it grow? Okay, how much of endometrium can you support? At a point, what happens? It will all shed. It will give away, and the lady is going to have bleeding. She'll have excessive bleeding. Okay, so this is the most common presenting feature of um, endometrial hyperplasia, or for that matter even endometrial carcinoma. Okay, so there could be other presenting features also, but something to be remembered is this is something you should never forget. Okay, so in a perimenstrual woman, she'll come with abnormal uterine bleeding, or a postmenopausal woman can come with postmenopausal bleeding. Okay, but if they ask what is the most common cause of postmenopausal bleeding, the most common cause is senile endometritis. Okay, it's in the name. So this is the inflammation of the endometrium. Okay, why? Because of age related. So what is happening here? There's atrophy. Okay, atrophy of the endometrium because of less estrogen. Okay, so that's the most common cause. Fine. So that is how the patient presents. Now what will you do? The next thing you have to do is a biopsy. Okay, so before we do a biopsy, what we'll do is, see, this is hyperplasia. You should just know how thick the endometrium is. So what we'll quickly do here, the investigation is, let's do a transvaginal ultrasound or transvaginal sonography. Okay, so then we're going to see the thickness of the endometrium. So if the lady is a premenopausal lady, the criteria is different, and if she's a postmenopausal lady, the criteria is different. Premenopausal, okay, if the endometrium is more or equal to 8 mm, then you have to be careful, because that means there is endometrial hyperplasia in this patient. Postmenopausal, thickness more than or equal to 4 mm. Okay, I'm sorry about this here. This should be more. Okay, more than equal to. Okay, it just depends on what it. Okay, anything more than equal to 8 mm in premenopausal is considered endometrial hyperplasia, and postmenopausal anything more than equal to 4 mm. So this figure is very, very important. Okay, fine. So you found out that there is thickness. Okay, there's thickening, or thickness of the endometrium is increased. Then what do you have to do? Okay, and then you will go ahead and do a curettage. You do an endometrial curettage. Okay, curettage. Okay, whatever it is. So you do this. Okay, you're going to go in and scrape the endometrium and take the biopsy. So hence you're going to get a biopsy. So you're going to study this. Okay, pathologist is going to examine this and tell you what kind of hyperplasia is it. Is it simple or is it complex? Is it having atypical cells or is it having typical cells? Now, the management of this will depend majorly on the type of cells. Okay, if there is presence of typical cell, it is different. If there is presence of atypical cells, it is different. Okay, so if there is presence of atypical cells, see, the risk is higher, isn't it? What is the risk? It is around 8% in simple typical, and it is 30% in complex atypical. Correct? So hence what we'll do is, here directly you have to go ahead and do a hysterectomy, because if you leave it like that, it will become carcinoma. It's better you take it off. But if the patient refuses to undergo hysterectomy, okay, then what is the drug we are going to give? Here we are going to give progesterone. Okay, because see, the logic is very simple. We said endometrium grows when there is estrogen, and what happens in the second half of the menstrual cycle? The progesterone maintains the endometrium. Okay, it prevents the endometrium from getting shed, because here the symptom is excessive bleeding. So what we'll do is we start progesterone, so hence the endometrium will be maintained. So what we will do is we'll give either continuous or cyclical progesterone. This could be continuous or could be cyclical progesterone for a period of 6 months. So which progesterone is given here? That is called as megestrol. Okay, here that progesterone has a specific name. It is called as megestrol. Okay. Now otherwise typical cells, it is, you can just manage here with progesterone only. Okay, simple. So if it is simple or complex, okay, with typical cell, what you will do, it is you will try to manage it with hormones, that is progesterone. But if they are atypical cell, because the risk of carcinoma is higher, we'll straight away go for hysterectomy. Okay, that is how you manage hyperplasia, endometrial hyperplasia. So now let us go ahead and discuss about carcinoma. Okay, endometrial carcinoma. Okay, here things are very similar to hyperplasia. Let's see how it happens. And see, we've told hyperplasia is a premalignant condition. If not treated or identified, it will go in for endometrial carcinoma. Okay, so hence the risk factors will remain the same, right, as it is. Okay, we're going to mention here, and the risk factor in this, what we'll have to include here, we'll have to include one extra point, that would be endometrial hyperplasia. What kind of endometrial hyperplasia? Atypical. Okay, right. So these are the risk factors for endometrial carcinoma. Fine, let's just get some facts clear here. So which is the most common type of endometrial carcinoma? It is adenocarcinoma. Okay, because we're talking about glands. So this endometrium is having, it is rich in glands, correct? So they will undergo proliferation, neoplastic proliferation, and give rise to adenocarcinoma. So there are different grades in this. Okay, pathologically we have grade 1, 2, and 3. Okay, these two are having better prognosis compared to this third grade. Okay, grade 3. Okay, fine. Next, there are other types. It's just not adenocarcinoma. You could have adenosquamous type, okay, where you have a combination of adenocarcinoma and a variety of squamous cell carcinoma there. And then we have papillary serous. This is important. Along with this, we have clear cell adenocarcinoma. Okay, so what is important about papillary serous carcinoma? This is going to spread early. Okay, it spreads early. Okay, and clear cell adenocarcinoma is associated with the worst prognosis. Okay, so that is regarding the histological types or variants of endometrial carcinoma. Okay, so next, if they ask which is the most common genital tract malignancy in India, okay, so the answer is CA cervix. There's no question. Okay, in India, or if they say any developing country, it is going to be CA cervix. If they instead they asked in a developed country, okay, it is going to be CA endometrium. Okay, so that's the importance. And if they say most common genital tract malignancy in the world, okay, then it is again going to be CA cervix. Okay, fine. And if they ask which is the most common malignancy in females or in women, okay, the answer is going to be CA breast. Okay, so these are some most commons that needs to be remembered. Okay, so we have seen the patient has come. Okay, the patient has CA endometrium, let's say. The risk factors have been explained, and then the clinical features. Clinical features is similar to hyperplasia again. They will come with either AUB if she's perimenopausal. She'll come with postmenopausal bleeding. Okay, then or they can come with the pyometra. So what is pyometra? Pus inside the uterus. Okay, so if this is the uterus, so there'll be hyperplasia. There'll be growing of the tissue here like that. So there'll be a lot of secretion and all. It can get accumulated here and get infected. So you'll have pyometra. Okay, sometimes rarely they can have hypogastric pain also. Hypogastric pain. Okay. Then okay, that's pretty much it. That's the most common presenting symptoms of CA endometrium. So next, what will we do here? Again, we have to stage the patient. Okay, we have to do the staging. Here, staging is surgical, very important. In CA cervix, we discussed that staging is clinical. Okay, and we said that we did not supposed to use 4 investigations for staging. What were they? CT, MRI, ultrasound, and PET scan. Okay, these are not supposed to be used. Here, the staging is all clinical, but here the staging is all surgical. Okay, so what is that surgery we are going to do so that we'll stage it? See, we are going to do a hysterectomy. Okay, we're going to do a total abdominal hysterectomy. Okay, so we are going to do a total abdominal hysterectomy. We're going to do bilateral salpingo-oophorectomy with pelvic and para-aortic lymph node sampling or dissection. Okay, we're going to see that. So basically we will do this. We are going to take these samples and we're going to study if there is tumor cells in these areas, and we will come to know how far the tumor has gone. Okay, now let us go into the staging. Okay, staging. So how do we describe this? There are 4 stages. Okay, let us first talk about stage 1. Stage 1 meaning it is confined to the uterus. Okay, so again we have 1A and 1B. 1A meaning the tumor is within the endometrium or it involves less than 50% of the myometrium. Okay, simple, fine. 1B is it involves more than 50% of the myometrium. Okay, next we go to stage 2. Stage 2, from uterus it is now spreading out. Okay, it is going to the cervix. So stage 2, it involves the cervix. Which part? The stromal part of the cervix, of the endocervix. Okay, right, the stromal part of endocervix. Clear? If the glands are involved, it is not stage 2, it is still stage 1. Okay, clear, fine. Now let's go to stage 3. Stage 3, we have A, B and C. A meaning it is gone to the serosa, or it is gone into the adnexa. It is involving the serosa of the uterus or the adnexa. So it is spread laterally. B meaning it has come to involve the vagina. So it is spread downwards, that is vertically. Then C meaning it is involving the pelvic and the para-aortic lymph nodes. So again they usually call it 3C1. 3C1 is pelvic, 3C2 is para-aortic. Okay, then we go to stage 4. Stage 4 is metastasis, correct? Again we have A and B. A meaning the local structures, so surrounding structures. We have the bladder and the bowel. B meaning distant metastasis, which will also include your inguinal lymph nodes here. Okay, inguinal lymph nodes. So that is about the staging. So the patient has come, there are symptoms, you will do the surgery and you are going to stage the patient. Okay, in which stage this one your patient is. Okay, now we'll have to treat the patient. Okay, so let's see the management or the treatment. Okay, so you talked about the staging. Let's just quickly write the corresponding treatment that we are going to give. Okay, so if it is stage 1, okay, what did we say? Stage 1 is confined to the uterus. So again we said stage A, 1A and 1B. Okay, A is less than 50% of the myometrium involved. B is more than 50% of the myometrium involved. Here we are just going to do the surgery. What is the surgery? We know total abdominal hysterectomy, bilateral salpingo-oophorectomy, and you're going to do the lymph node sampling. Which are the lymph nodes? Pelvic and para-aortic. Okay, you do that surgery. Following that, you're going to follow up the patient. Okay, and moreover there is nothing that is left behind. The uterus was involved, so you've taken out the whole of the uterus. Okay, there is no spreading also, so that's not at all a problem. Now for this, okay, what we are going to do, it has gone beyond, meaning more than 50% of the myometrium, so it might have gone into the surrounding lymph nodes. Now what you have to do, you have to do the surgery. What is that? Total abdominal hysterectomy with bilateral salpingo-oophorectomy, and here we are going to do the lymph node dissection. Here we said lymph node sampling. Okay, we're just going to take the samples and check if the malignant cells have come there or not. But here you're going to do lymph node dissection. Which are the lymph nodes we are going to take it out here? They're pelvic and para-aortic. Okay, fine. Following this, we have to do a post-op radiotherapy. Very important. You will have to do a post-operative radiotherapy. Next, coming on to stage 2. Stage 2 management is also just as this. Okay, 1B. Okay, stage 2 is just as 1B. Cool. Okay, then we come to stage 3 and 4. See, in stage 3 and 4, if the tumor is big, then you can go for debulking surgery, or otherwise the protocol would be chemotherapy. I'm going to start the patient chemo and you're going to give radiotherapy. Okay, so chemotherapy and radiotherapy. Chemotherapy with cisplatin or carboplatin or paclitaxel So with drugs like that, okay, so we're gonna do chemotherapy, give chemotherapy, and then we can give radiotherapy. If the tumor, if the malignancy is hormone receptor, probably you can give even hormonal therapy. Okay, okay, fine. So that's about the management part. And there's one risk that is associated with the C endometrium. There could be recurrence. Okay, let's talk about recurrence. It will usually occur within first 2 years of surgery. Okay, and the most common location would be vagina and the pelvis. Okay, so hence the most common presentation would be bleeding again. Okay, fine. So that comes that finishes most of the important things regarding C endometrium. So and some things that I might have forgotten, I would like try to mention it here. There is something called Lynch 2 syndrome, okay, which is basically another name for HNPCC. So it is associated with colon cancer, endometrial cancer, even ovarian cancers. Okay, so that is another risk factor, actually, familial. Okay, familial factor in the development of endometrial carcinoma. And then age group, this is very important. Age group for the development of endometrial carcinoma is like 55 years to 70 years. So on average, you can remember average as 60 years. So it's an old lady, right? So usually postmenopausal, right, coming with postmenopausal bleeding. So first cause you need to rule out is senile endometritis. So the first thing you're going to do is do a transvaginal sonography and see what is the thickness of the endometrium. Correct? Okay. Then there is one thing that might be important. Okay, we have two types. Okay, we call it type 1 endometrial carcinoma and type 2 endometrial carcinoma. Okay, so type 1 is nothing but your normal adenocarcinoma grade 1 and 2. Okay, fine. Then here grade 2 is adenocarcinoma, type 2 is adenocarcinoma grade 3, and all other types. What did we discuss? We discussed papillary serous type, and we also discussed clear cell variant. Okay, so that all comes under type 2. Now obviously, so from this what can we make out? This is associated with good prognosis. Type 1 is having good prognosis, and all our risk factors we studied will hold good here. Okay, we said some obese lady who is having hypertension and diabetes, and she's okay, whites, basically this is common in whites. Okay, on the other hand, this is associated with poor prognosis or bad prognosis. Okay, you're going to have a thin lady, okay, thin female who is black, okay, black female. So these are the things that are associated with type 2. And there's everything is like typical about what type 1, okay, about what we have studied. So it will be estrogen dependent. So this is not dependent on estrogen. Cool. So type 2 is bad. So sometimes this kind of classification might be asked. Okay, and so we have seen about the clinical stages. Is pap smear useful here? If this is one of the questions that might be asked. See, pap smear it is just exfoliative cytology, right? So pap smear is exfoliative cytology. So it just tells that the cells are abnormal. You don't really get to know from where the cells are coming. Okay, so only in 10% of endometrial carcinoma cases you will get abnormal cells in the pap smear. Okay, so it's only in 10% cases it is seen, but hence it is not routinely done. See, you will miss off, right? So the sensitivity is kind of low, so that's why we will not. Pap smear is not a routine mode. And okay, there are methods that if you want to do this one investigations. What are the investigations to see endometrium? You'll see things like aspiration, endometrial aspiration. Okay, then you will see endometrial curettage. Okay, we have something called dilation and curettage, DNC, that is what it is popularly called. And we have endometrial biopsy. Okay, let's get things clear here. So endometrial aspiration is that you're going to put a this one. There will be devices, okay, meant for this aspiration. You have Carmen's cannula and all. So you just put it inside the cervix. You're just going to aspirate the endometrium. Okay, so this is going to be the first investigation. Okay, if someone asks what is the first investigation you want to do, okay, then the answer is going to be after your TVS, that is transvaginal sonography and all. Once you know that there is thickening and so on, the first investigation this postmenopausal woman you're going to do is endometrial aspiration. But the best is biopsy. Okay, earlier we used to say that DNC is the best, but nowadays it's endometrial biopsy. So how you're going to take the biopsy? It's basically hysteroscopic. Now there's one more point here. Okay, hysteroscopy. Okay, so when you do hysteroscopy, you're going to put a scope inside, you're going to fill the uterus with saline and so on, right? So it's going to, you're like giving a wash. So where does the fluid go? Okay, this is the uterus, these are the tubes, this is the femoral end, right? It looks very weird, but yeah, fine, this is understandable. So when we put saline from here, okay, it's going to wash off the tumor cell. It goes into your salpinx, basically your tubes, and it will go into the peritoneum. So that is why they say it shouldn't be like hysteroscopy should not be usually done in a known case of endometrial carcinoma. But if you have focal lesions, okay, see, when you're doing this curettage and stuff like aspiration and all, so you don't really target a particular area. You're going to just get the cells, okay, from the endometrium. But when you can see some focal area on your ultrasound, let's say, then to pick up biopsy, to pick up that particular tissue, you will have to do hysteroscopy and then hysteroscopic guided biopsy, which will be the best investigation. Okay, and let us say that we are doing the staging. Okay, so in staging, to know to what extent the endometrium is involved, so the investigation of choice there would be MRI. Okay, you know MRI, you know to what depth, okay, to what depth the myometrium is involved. Okay, myometrium is involved. So hence it will help you in staging. That is stage 1A or 1B. Okay, fine. So I think that completes CA endometrium. Okay, thank you. See you in the next video.